Okay, are we live? Let me confirm it once. Okay, are we? Yes, let's start from where we left in the last session. We completed hyperparathyroidism. Okay, we start from diabetes mellitus. Okay, acute manifestation, polydipsia, polyuria, polyphagia, three P's. Weight, weight loss, DKA, diabetes ketoacidosis type 1, hyperosmolar hyperglycemic stage type 2. Rarely can be caused by unopposed secretion of growth hormone and epinephrine. Also seen in patient on glucocorticoid therapy, steroid diabetes. Okay. Acute manifestation, polydipsia, polyuria, polyphagia. Okay. Weight loss, diabetic ketoacidosis type 1, hyperosmolar hyperglycemic state in type 2. Rarely can be caused by unopposed secretion of growth hormone and epinephrine, also seen in patient on glucocorticoid therapy. Okay. Steroid diabetes. Chronic complication, non-enzymatic glycation, small vessels disease, hyaline artio atherosclerosis, or retinopathy, neuropathy, nephropathy, large vessel disease, atherosclerosis, that is arteriosclerosis. This is atherosclerosis. CAD, coronary artery disease, cerebrovascular disease, peripheral vascular disease. MI is most common cause of death. Okay. Osmotic changes, sorbitol accumulation in organs with aldose reductase and decreased or absent sorbitol dehydrogenase. Neuropathy, motor, sensory, glove and stocking distribution. Autonomic degeneration, that is GERD. Gastroparesis, diabetic diarrhea, cataract. Diagnosis, test, diagnostic cutoff and notes. HbA1c more than more than or equal to 6.5 percentage. Reflect average blood glucose over period 3 months, influenced by RBC turnover. Fasting plasma glucose more than 126 milligram per deciliter. Fasting for more than 8 hours. 2-hour glucose tolerance test, more than 200 milligram per deciliter. 2 hours after consumption of 70 gram of glucose in water. 75 gram of glucose in water. Random plasma glucose more than 200 milligram per deciliter. Presence of hyperglycemic symptoms is required. Okay. Let's see the flow chart now. Decreased available insulin. If available insulin is low in the body, it leads to lipolysis, increased proteolysis, gluconeogenesis, glycogenolysis, decreased tissue glucose uptake. All of this leads to the following things. Let's start with lipolysis. Low available insulin leads to increased lipolysis, leads to increased plasma free fatty acid, increased ketogenesis, ketonemia, ketouria. It can lead to vomiting and loss of sodium and potassium, loss of water. It can lead to hypovolemia, can lead to circulation failure, decreased tissue perforation. Also, increased ketogenesis, ketomia, ketouria leads to anion gap, metabolic acidosis. It can lead to hyperventilation, Kussmaul's respiration. Okay. Increased proteolysis, decreased muscle mass and weight loss. It also leads to gluconeogenesis. Okay. Increased gluconeogenesis, increased glycogenolysis, hypoglycemia, glycosuria. This can lead to osmotic diuresis, loss of water, sodium, potassium, hypovolemia, circulation failure, decreased tissue perfusion, increased plasma osmolality, increased thrust. Yes, got it. Now we'll differentiate type 1 and type 2 diabetes mellitus. Type 1, type 2. Primary defect, autoimmune T cell mediated destructions of beta cells in primary. In secondary, increased resistance to insulin, progressive pancreatic beta cell failure. Okay. Insulin necessary in treatment in type 1 always, type 2 sometimes. Age exceptions common. Less than 30 years in type 1, more than 40 years in type 2. Associated with obesity, type 1 no, type 2 yes. Genetic predisposition in type 1 relatively weak, 50% concordance in identical twins. Polygenic, relatively strong, 90% concordance in identical twins and polygenic. Associated with HLA system, type 1 yes, HLA DR4 and DR3. 4-3 is equal to type 1, mnemonic. Type 2 not associated with HLA system. Glucose intolerance in type 1 severe, in type 2 low. In type 2 mild to moderate, not low. Insulin sensitivity high in type 1, low in type 2. Ketoacidosis common in type 1, rarely in type 2. Beta cells number in islets in type 1 decreases because destructions of T cell mediated, destructions of autoimmune T cell mediated destructions of beta cells. Variable with amyloid deposits. Serum insulin level decreases. Type 2 increases initially but decreases in advanced disease. serum insulin level decreases and okay, beta cells numbers in islet variable with amyloid deposits in type 2. Serum insulin level in type 1 decreases, in type 2 increases initially, but in advanced disease decreases. Okay, because progressive pancreatic beta cell failure. Classic symptoms of polyuria, polydipsia, polyphagia, weight loss. In type 1, yes. In type 2, sometimes. Histology, islet leukocytic infiltrate, we can see. Type 2, islet amyloid polypeptide deposits, we can see. Hyperglycemic emergencies, diabetic ketoacidosis, hyperosmolar hyperglycemic state. Pathogenesis, insulin non-compliance or increased requirements due to increased stress, that is infection, lipolysis, oxidation of free fatty acids, increased ketone bodies, beta hydroxy butyrate more than acetoacetate, insulin deficient, ketone present. Hyperglycemic emergencies. What we can understand from this word is there is more glucose in the blood and it can lead to some emergencies. We are studying that diabetic ketoacidosis, hyperosmolar hyperglycemic state. Pathogenesis of diabetic ketoacidosis, insulin non-compliance or increased requirements due to increased stress, that is infection, leads to lipolysis and oxidation of free fatty acids, leads to increase in ketone bodies, beta hydroxybutyrate more than acetoacetate. Insulin is deficient, ketones present. In hyperosmolar hyperglycemic state, profound hyperglycemia, excessive osmotic diuresis, dehydration, increased serum osmolarity, leads to hyperosmolar hyperglycemic state. Classically seen in older patients with type 2 diabetes mellitus and limited to ability to drink. Insulin present, ketone deficient, ketones deficient. Signs and symptoms, diabetic ketoacidosis is deadly, delirium / psychosis, small respiration, rapid deep breathing, abnormal pain, nausea, vomiting, dehydration, fruity breath, odor due to exhaled acetone, thirst, polyuria, lethargy, focal neurogenic deficit, seizures. Sign and symptoms in diabetic ketoacidosis. Diabetic ketoacidosis is deadly, delirium, psychosis, small respiration, rapid deep breathing, abdominal pain, nausea, vomiting, dehydration, fruity breath, odor due to exhaled acetone. In hyperosmolar hyperglycemic state, thirst, polyuria, lethargy, focal neurologic deficit, seizures. In lab, hyperglycemia increases H+, decreases SCO3, increases anion gap, metabolic acidosis, hyperglycemia, increase H+, decrease SCO3, increased anion gap metabolic acidosis, increased urine and blood ketone levels, leukocytosis, normal or increased serum potassium, but depleted intracellular potassium due to transcellular shift from decreased insulin and acidosis. Osmotic diuresis, increased potassium loss in urine, total body potassium depletion. I have seen this patient in my emergency postings. Hyperglycemia, often more than 600 milligram per deciliter, increased serum osmolality more than 320 milliosmoles per kg, normal pH, no acidosis, no ketones, normal or increased serum potassium, decreased intracellular potassium. Okay, once again in hyperosmolar hyperglycemic state, hyperglycemia often more than 600 milligram per deciliter, increased serum osmolarity more than 320 milliosmol per kg, normal pH, no acidosis, no ketones, normal or increased serum potassium or decreased intracellular potassium. Okay. Complication: diabetic ketoacidosis is life threatening, cerebral edema, cerebral edema, cardiac arrhythmias, life threatening mucormycosis, cerebral edema, cardiac arrhythmias, can progress to coma and death if untreated. Hyperosmolar hyperglycemic state. Treatment: IV fluids, IV insulin and potassium to replete intracellular stores. Glucose may be required to prevent hypoglycemia from insulin therapy. Treatment for both is same: IV fluids, IV insulin, potassium to replete intracellular stores. Glucose may be required to prevent hypoglycemia from insulin therapy. Got it? Next, hypoglycemia in diabetes mellitus. Usually occurs in patient treated with insulin or insulin secretagogues, that is sulfonylureas, meglitinides, in the setting of high dose treatment, inadequate food intake and or exercise. Okay, hypoglycemia in diabetes mellitus usually occur in patients treated with insulin or insulin secretagogues, understandable, that is sulfonylureas and meglitinides in setting of high dose treatment. Yes, inadequate food intake and or exercise. Neurogenic autoimmune symptoms. No, not autoimmune. Neurogenic is autonomic symptoms. Diaphoresis, tachycardia, tremors, anxiety, hunger. Allow perception of decreased glucose, hypoglycemia awareness. neuroglycopenic symptoms, altered mental status, seizures, death due to insufficient glucose in CNS may occur in the preceding neurogenic symptoms in patients with attenuated autonomic response, hypoglycemia, unawareness. Okay. Treatment simple carbohydrates, that is glucose tablets, fruit juice. Intramuscular IM glucagon, IV dextrose. Next is Cushing's syndrome. This is going to be our last topic for today. Etiology: increased cortisol due to variety of causes. Exogenous glucocorticoid decreases adrenocorticotropic hormone. Bilateral adrenal atrophy, most common cause. Exogenous glucocorticoids. Primary adrenal adenoma. Primary adrenal adenoma, hyperplasias, carcinoma, decreased adrenocorticotropic hormone leads to atrophy of uninvolved adrenal gland. Oh, okay. Adrenocorticotropic hormone secreting pituitary adenoma, Cushing's disease, paraneoplastic ACTH, that is small cell cancer, bronchial carcinoids, bilateral adrenal hyperplasia. Cushing's disease is responsible for majority of endogenous case of Cushing's syndrome. ACTH secreting pituitary adenoma, that is Cushing's disease. Paraneoplastic ACTH secretion, that is small cell cancer, bronchial carcinoids. Bilateral adrenal hyperplasia. Cushing's disease is responsible for majority of endogenous cases of Cushing's syndrome. Okay. Etiology is increased cortisol due to variety of reasons. That is the etiology for Cushing's syndrome. Findings: moon phases, metabolic syndrome, hypertension, hyperglycemia, hyperlipidemia, obesity, truncal weight gain with wasting of extremities, round moon phases. A, shown in figure A, image A. Dorso cervical fat pad, buffalo hump, osteoporosis, neuropsychiatric, depression, anxiety, irritability, facial plethora, androgen excess, acne, hirsutism, cataract, immune suppression, ecchymosis, easy bruising, skin changes, thinning, A. Hyperpigmentation. Diagnosis screening test include increased free cortisol on 24-hour urine analysis, increased late night salivary cortisol, and no suppression with overnight low dose of dexamethasone test. Okay. Diagnosis screening test include increased free cortisol on 24-hour urine analysis, increased late night salivary cortisol, no suppression with overnight low dose of dexamethasone test. Okay. Increased, let's see overall Cushing syndrome. Increased 24-hour free urine cortisol, increased late night salivary cortisol, and or inadequate suppression of 1 gram overnight dexamethasone test. Major serum ACTH, suppressed or elevated. If suppressed, ACTH independent Cushing syndrome. Major serum ACTH if suppressed, ACTH independent Cushing syndrome, exogenous glucocorticoid or adrenal tumor. Consider adrenal CT to confirm. If elevated ACTH dependent Cushing syndrome, high dose dexamethasone suppression test. CRH corticotropin releasing stimulating test. If no, ectopic ACTH secretion. Okay. ACTH cortisol, Cushing's disease, MRI of pituitary, ectopic, increase ACTH cortisol, Cushing's disease, CRH stimulation test. Okay, got it. If no, ectopic ACTH secretion, CT of chest, abdomen, pelvis to identify tumor. Okay, and that's it. We have completed our today's session. Not today's, this session of reading USMLE first aid, and we have covered Cushing syndrome, hyperglycemia in diabetes mellitus, hyperglycemic emergencies, type 1 versus type 2 diabetes mellitus, and diabetes mellitus. We have read this in the last 30 minutes and we are very happy with it, and we are going to end this session.